particular topic related to endodontics. This is my specialization, and today we're going to speak about root resorption. There is a singular topic because it's quite unknown. So it would be very nice to share with you the knowledge and how today we are going to treat this kind of pathology. Now, this pathology is quite unknown and often is misdiagnosed and more poorly managed. So it's very important to have a common knowledge in order to understand this kind of pathology and to treat in the same way in order to be able to share our knowledge all over the world. And we must know, we must learn to know it. We have to improve our knowledge. And once we understand, this pathology, what can we do? What to do is always an equilibrium between what we know and what is right. What do I mean? I mean that what is right for the patient is not always the best therapy we can do. So we need help, and who can help us? For example, the International Society of Endodontics. This is a topic by American Association of Endodontists, and today I will use two statements for this speech. One from the American Association of Endodontics, another from the European Society of Endodontics. In this case, American Association tells us that it's always better to save the tooth. It's normal and it's our work, but it's not always achievable, this kind of therapy. So what to do? There is a lot of literature that comes to help us and to understand what can be the best performance for our patients. And this is the statement of American Association of Endodontics. It has been made some years ago. There is a newly performed statement by European Society, but it's always right. And it's always good to understand and to study. You are all students, and is your job to study, but also my job. I am a professor, I'm a clinician, but I every day read an article or something new to improve my knowledge and to improve my clinic. So I hope you will do the same for the years on. And this is the European Society of Endodontology statement. It's newly because it's from 2022. And there are 3 articles about this. These are the 2 main articles, and the position statement about root resorption, and the present status and future direction about root resorption. So these 2 articles tell us how to understand this kind of pathology and how to face it and to treat it. So now we know where to look at, and getting back, we must know and learn how the resorption works, because it's a strange pathology and it doesn't work like carious lesion or like periodontal lesion. It's a different process, and we must know how it works. And we have to face how they work, how they look, how what we see in the mouth of our patients, and how to treat them. These 3 topics are very important because we have to know everything about every one of this topic. Because if we don't know the process, they perform, we cannot understand how can be our intervention, how they look, because we need to recognize them. For example, we can see a lesion. They can seem to be a carious lesion instead of a cervical resorption, for example. And then, understanding how they work and how they look, we can understand how to treat them and how to save the teeth for our patients. The physiology of resorption is very important because in natural teeth, the only physiological resorption is in the deciduous teeth. And this is very important because this is what happens into a deciduous teeth. So while the permanent teeth come towards the occlusal plane, there is a resorption of the root of the decay of the deciduous tooth. So this is how a resorption works. But this is the only physiological way in which a resorption can be performed in our body. The same process with a different scenario comes to a pathological condition. So whenever we see a resorption in a non-deciduous teeth, in a permanent teeth, it's always a pathological condition. And it's very important to understand this. And the problem is why teeth do not resorb physiologically. Why only the deciduous teeth go towards this destiny? It's a particular kind of system inside our teeth. We have two systems of defense, and these are the precementum and the predentum. Are two layers that stay inside and outside the root dentin, the radicular dentin, and this layer prevent the possibility of osteoclast cell to destroy our dentin. It's very important because this is the key. This is the key of the working teeth or the decaying teeth. And the possibility to understand how they work lead us to understand how to treat the problems or how to understand when a tooth is healthy. Now, we understood the physiological way. We understood why normal teeth do not go towards a resorption and why the deciduous teeth instead goes towards a physiological resorption. Now we have to go to the dark side of the moon, to the pathological way. And we have to understand what is it. The definition by Patel in the European Endodontics Society statement tells us that the loss of hard tissue in the tooth due to odontoclast action is a root resorption. It can be internal or external. This is very important because leads us to understand the way the way root resorption goes inside the teeth. It's some kind of autoimmune pathology because it's our body destroying our teeth and not external agents like bacteria in the periodontal problems and in the decaying teeth, in carious lesion. It's always the bacteria that works against our teeth, against our systems of defense. Now, this is an opposite situation because our system of defense is working against our teeth. So it's very important because, for example, antimicrobial action, antimicrobial therapies doesn't solve the problem. We have to work in a surgical way. We're going to see how to do it. Resorption are caused by a damage on root cementum on or odontoblast layer inside the tooth surface. This allows the class cell in the bloodstream to access the dentin. So the layers, the outer and the inner layers, become weak in some point or in one point, and this weak point is the door to where odontoclast cell can access the dentin. And this is, like Leighton say, the primum movens, the original problem that lead to the resorption. There are different places where it can be this situation, and we are going, do not look at what written. I need for you to focus on the image, and these are the different doors where odontoclasts can work to, against our tooth, and we are going to see any one of them. And every entrance lead to a different kind of resorption. So we need to classify all the resorption in order to understand where it is the lesion, where it's going to work, and how can we act against this. We need two phases. It is very important because in every kind of resorption, we need an initial damage and a stimulation. The combined action of these two situations lead to the resorption. So if we have a damage without a continuous stimulation, there cannot be a resorption. And if we have the stimulation, but there is no damage, so the inner and the outer layer of defense are okay, there cannot be a damage. So this is very important because we are lucky, because it's not simple to have these two situations together. But when they come together, there is a problem. And this problem can be very, very important and very, very dangerous for our teeth. The initial damage can be mechanical or chemical. The first family, the mechanical family, sees trauma, cancer, surgery, impacted teeth, and orthodontics. Now we see that we can be the first cause of the resorption, because of course the trauma is not about us, also the cancer, but surgery, surgical action, or orthodontic action can be a very important primum movens to create the initial damage to lead to a process of resorption. And also impacted teeth can be a problem because they can work against the root of other teeth, and the moving impacting teeth during the physiological moving or during orthodontics procedure can lead to the initial damage. The chemical way is all about us because is the bleaching the most important reason, and can be external or internal. So the performing of external bleaching without a protection at the level of the CAJ can lead to cervical resorption. Instead of also the internal resorption, internal bleaching can lead to a resorption if we do not protect the dentin of the root. So when you're about to perform an internal bleaching, it's very, very important to isolate the internal part of the tooth, I mean the radicular part. So you have to put something coronal to the CAJ in order to isolate. In my practice, I always put a composite. I always do a filling, so adhesive procedure and the composite filling, in order to have a camera. The pulp chamber can be isolated from the root and from the external agent. This is the only way for you to perform a good internal bleaching. For the result and to protect the tooth from the internal resorption. Now, let's speak about traumas, because in the university, I often deal with the trauma in child, and this is one of the most important reasons about resorption. Sometimes a child comes to me also with a resorption, sometimes teens comes to me with a resorption, and sometimes adults tells me about a former story of trauma that lead to a resorption. So the main resorption in teeth is, of course, in the frontal teeth, because when we have a trauma, the first teeth the trauma can work with are incisor or canines, of course. And we must make difference between adult and kid. So the alveolar process in the adult is stiff. If we have stiff bone, the trauma on teeth can hesitate in fracture because the root do not move, and the energy of the trauma is so to the crown that goes to a fracture. In kid, the alveolar process is soft. That can be advantage or a disadvantage, because there can be an avulsion, and an avulsion can be a lucky situation if the kid meets a good dentist that knows what to do, but he had to meet a dentist and not a general doctor. And he must know the right procedure to replace, to re-put the tooth in the right position, to block the tooth in a good way, and to understand where the tooth need a root canal therapy inside the mouth or outside the mouth. This is very, very important. If normally in Italy, if we have a trauma, kid goes to the emergency in the hospital, and not always there is a dentist down there. So not always emergency doctors know how to do, and maybe the procedure can lead a problem. This is the case of Alice. We will see her later. We will meet her later again. And we can see that the reposition of the tooth led to an external resorption, substitutive resorption, the worst situation we can face, but we are going to meet her later. This is the incidence of resorption after reimplantation. And it's very, very important to see the last voice, the substitutive resorption in the 50% of reimplantation. It is very important because half of the teeth you will re-put inside the mouth will go towards substitutive resorption. And the way you can avoid this is only by following the right procedure and the right protocols. It's very important to understand and to study every situation. Now, this is Alice, the girl we met before. We virtually met. What happened? She fell from the bike, and she had a trauma on the lip, on the face, and both the central incisor went out. Which was the problem? They found the tooth 2 hours and 4 hours after the injury. So she went on the emergency department of the hospital, but the father came with one teeth 2 hours later. 2 hours, you know, it's a long time for to re-put the teeth in its position without a root canal therapy. But of course, the general doctor didn't know this, so he replaced one teeth, the right incisor, and then 4 hours the father came with the other tooth, that he found inside the grass. And of course, it was very infected, normal. And they report this tooth 4 hours later. What we had to do, they had to go to the dentist, and they had to tell the dentist what happened, and their dentist should made a root canal therapy. This did not happen. You can see in the RX, and she came to me with an abscess on, so pain. She was 8 years old, pain, phlegm, and very critical situation. So the only thing I could do was a root canal therapy inside the mouth. These teeth were in ankylosis, so we cannot move or remove them. I prefer to fill all the root canal with bioceramic, because bioceramic become very hard and can create a chemical link with the dentin. So my objective was to create an entire entity, a single entity with the root and with a cementum, in order to reinforce the tooth, because a problem could occur, can be the fracture of the apical part of this tooth. And performing a root canal therapy allowed me to reduce the inflammatory situation around the tooth, and the inflammation lead to the resorption. So my objective was to try to stop the resorption, eliminating the inflammatory situation. And this is the immediate postoperative RX. This is the 1 year control, and it seemed to be the same situation we met the year before. So I'm optimistic about this. And this is the 2 year follow-up. The difference of the RX is because I made in another emergency clinic, another emergency department, but I can tell you that the situation is the same. I saw her last week. I could not take the RX with me, but this is the 5 year control, and the teeth are still there. I'm optimistic about that. I think we've been lucky, but there is a problem. She has a deep bite, and the deep bite is a problem because the trauma, the continuous trauma on these teeth can create another resorption on this teeth. But we cannot move them orthodontically because they are in ankylosis. So we can act only in the lower jaw, moving the teeth far from this tube, because our objective is not to re-alienate, to align these teeth, but to keep them in the mouth until we'll be able to put 2 implants. Because if this girl lose these teeth before the 23, 25, or 30 years, now we know that the growth of the fascial of the face is going on until 25 years. So we can put implants after this date. So I have to be able to these teeth must be able to remain in the mouth from 8 to 25 years. So it's 18 years time. It's very long time. And I'm not so positive about this, but this is the only thing we can do. And we are in 5 of 18. 5 of 18 is more than nothing. So I hope we will meet in 10 years together, and I hope to be able to show you the 15 years control. Now, diagnosis of resorption. We have to put a good and a right diagnosis in order to understand that this is a resorption, in order to perform the right therapy. The problem is that resorption doesn't hurt. Seems to be a good thing but not for the diagnosis, because often is a casual finding, and late diagnosis is usually radiographic, and often is a late diagnosis, so the therapy can be not healing of this pathology. European Society of Endodontology and the American Association of Endodontists tells us that CBCT must be used only in addition, because the first exam to perform is a periapical EREX. This is always the first things we have to do. After this, if we have we are suspicious about resorption, we can perform a CBCT. And if we have a resorption, CBCT must be done every time, because we need a three-dimensional image of the situation in order to understand the gravity of the situation and the therapy, but in the second time. And after the individuation, after we came through resorption, we must classificate it. And classification of resorption are very lot. We can find 10, 12 classifications. So we have to choose one and to use this. And I will tell you what we will use about this. Resorption can be internal or external. So when we see a resorption, we can find them inside the tooth or in the outside part, but they can be combined. How? In the late diagnosis, an internal resorption can go through the dentin and towards the periodontal space. Also, external resorption can go inside the dentin and inside the pulp. All of these can be superficial, inflammatory, or substitutive. And the external resorption can be cervical. The cervical resorption is a different kind, and all the clinicians can prefer to individuate a specific family about cervical resorption. Now, let's have a look at the internal resorption. So, inflammatory. The inflammatory resorption is like a round lesion inside the canal. And what happens? Trauma, a problem, an inflammation, a necrosis lead to a problem, a damage on the inner layer, so in the predentin. And the damage to this inner layer stimulate the odontoclast to perform a resorption, and this resorption is always or quite always round inside the root. And we can see like this. It can be small, like the third image, big, like the first image, destructive, like the second and the fourth image. These are three situations of the same pathology. The difference is about the time. The time we come through this situation. So the third image is the first part in the first story of the resorption. The last is a lost tooth, because even if you perform endodontic surgery, there remain a few root to maintain the tooth inside the mouth. So this is a problem. But if you come through with lesion in the first times of the situation of the pathology, you can go through only a root canal therapy and save the tooth. This is what happens inside the canal. There is the resorption, and the tissue coronal to the resorption is always necrotic. So there is a necrosis towards the crown. The blood vessels towards the apex are healthy, so the tooth is vital. So what you have to do? In ideal situation, you could perform therapy only until you meet the resorption and maintain the vitality of the apical part. You are not always able to perform this, so maybe you will need a complete root canal therapy in order to stop the resorption and to maintain the tooth inside the mouth. The internal substitutive is a situation like this. It's similar to the former, but the image in the RX comes different because there is mottled image because a like bone tissue starts growing inside the tooth. This is a problem because this is not dentin. This is very bone-like tissue. And you have to face the situation, and you should remove all the bone-like tissue and remove all the inflamed tissue and perform a root canal therapy. It's very, very difficult because you always have conical instruments, and put a conical instrument inside this situation, inside this tooth, do not allow you to clean all the bubble. There are new kinds of endodontic instruments, like the expensive instrument, that can help you, but the most important thing you can do is work with EDTA and hypochlorite. This is the main thing you must do in order to remove chemically all the damaged tissue and be able to feel all the tooth in order to stop the resorption. This is a strange situation that sometimes can occur, the pink tooth, and it's typical to the internal resorption because the blood vessels create a red district inside the tooth, and the thin layer remaining of the enamel show the red inside, and so you can see purple or pink tooth, but it's very, very strange situation and not typical. So what can we do? We must know what to do about this. If we have a transitory resorption, we can only perform a monitoring. But if we come through necrosis, we must perform a root canal therapy. The progressive resorption need the root canal therapy, and of course, the substitutive. And if there is a perforation, if the resorption comes in the periodontal space, you must perform a repair. It can be under or above the bone level. If there is an underneath the bone level, you must repair it inside, going from the inside with the root repairing material. Above, you can make an intentional reimplantation. So you extract the tooth, you repair the lesion, and re-put the tooth inside the alveolar bone, or a normal surgery with a flap. The prognosis is good, so we can face it. Now, the external resorption is a little more difficult because the inflammatory resorption lead to a situation like this, and you cannot perform a surgical therapy in this situation because you must remove a lot of bone. It's not indicated. And this is only monitoring or extraction. And if it comes with a young guy, it can be a problem. So root canal therapy is important to eliminate the inflammatory situation. But if we have immature apex, we can perform an epixification with hydroxide of calcium, canal instrumentation and disinfection, then apical plug, or medication with the same material in order to be able to perform an apical plug. If we had a formed apex, we can instrumentate, disinfect, and perform a plug or a medication, and then a plug. The canal obturation must be performed in order to have a good prognosis. But the substitutive situation, the situation we met before with Alice, it's a problem because you must perform a root canal therapy with bioceramic and hope the teeth will last in the mouth as long as they can. And this long should be in our dreams a very long time. Age is important because in adults you perform the root canal therapy and you go monitoring annually. You can make prosthesis for infrarupted teeth in order to join, to reach the occlusal plane, but can hesitate with evolution. Then you can make autotransplantation or orthodontic closure of the space of prosthesis. If we have child, we must perform, of course, the root canal therapy, and then the process is the same because the outcome is the same of adult people. The prognosis is not good. I showed you before. We can only hope. Now, the superficial resorption is typical of orthodontic treatment. I am an orthodontist, and I can say that I never met a resorption like this, because if you are the orthodontist, you must use low forces in order to allow tooth not to resorb and to react to the forces you are performing. And you must remove the cause of the pressure. And there can be situation faced by the orthodontist of the surgeon, because the pressure can be done by a lesion, by a bone lesion, a traumatic lesion, tumor lesion. So the surgeon can be an important actor in this situation. And then wait. The residual root is very important, because if it's enough, you can monitor it and wait. If it's poor, you can go through a small occlusal load, and this is allow the tooth to remain in the mouth. But if we have a heavy load, this is the problem. This is a problem because we can go towards a possible evolution in a few times, in a lot of times, in a short time, sorry. But the prognosis can be good if we treat in a good way. Now, transitory apical breakdown. Transitory apical is a normal situation with lesion, with endodontic lesion, with orthodontic movements, with low forces. It's not a problem, but you have to understand it, to know it, and to stop the problem, to stop the cause, in order to let the tooth get healthy again. This is a summary of all the situation. You can find this image in the article showing you on the International Endodontic Journal, the journal of the European Society of Endodontics. And this is what I told you till now. Cervical resorption is another family, is another thing with another classification. This is the classical image you can find in the books, but also you can find this, because cervical resorption can be in frontal teeth, but also in posterior teeth. And you must understand also the second situation, because can be very, very problematic and can be impossible to solve the damage created by the resorption. And we will use these two classifications, Edersey and Patel. Edersey is the typical situation, the typical classification, and goes through 4 steps. The first is a less invasive lesion in the cervical area with poor presentation of the dentin. So a good situation, because if you can reach it, you can perform a normal filling with composite. Second situation is a well-defined lesion near the pulp area with none or poor presentation of the root dentin. So you are still in the crown or around the CAJ, and you can still face the situation. The third, it can start to become very problematic because there is an involvement, sorry for the automatic correction, of radicular dentin. The fourth situation is a problem because the lesion spread beyond the coronal third, inside the roof, all around the pulp chamber, and you cannot treat it without an extraction. This is the percentage of success in this situation. So in the first two, you got 100%, good. The third depend on the skills of the clinician. The fourth is not a problem of you as an endodontist, of course. But you have to think 3D because the landmarks are axial, circumferential, and with the pulp involvement. So the newly classification of the cervical resorption treat the height of the lesion, the circumferential diffusion, and the closeness to the pulp. These are the various situations you can face. And this is the article treating this new classification. I advise you because it's very beautiful, it's very well done, it's very important to read it. And this is what to do. For example, if I have one AD, so a lesion on the CAJ, less than 90 degrees of circumferential diffusion, and near the pulp, but not involving the pulp, I can perform an external repair. The problem is in the second family and, of course, in the fourth. The fourth situation of the first family is always lead to extraction. But you can perform an internal repair in the situation 2 and 3 with different circumferential spreading. And it's very important to know this classification because this is the difference between stable teeth and extracted teeth. And your hands are important, of course, but also your brain and your eyes are very, very important. Endodontics is maybe the only situation where brain, eyes, and hands must be always connected in order not to perform and to perform pure therapies and make damages. Repairing materials are 2 families: bioceramics, so root repairing materials, and composites. So you can perform a normal filling or repair the roof with biodentin, with the bioceramics of third generation. There are a lot of materials, and you must know them in order to understand which is the best in your hands. This is different repairing materials. And I have 2 or 3 minutes, so I'm going to show you some clinical cases. This is an internal resorption, and this is a newly formed internal resorption. So I performed the root canal therapy, a normal root canal therapy, and a normal rehabilitation with a normal filling in this tooth. So there is a 2 years control. I have, I think, the 10 years control, so everything went in a good way. External resorption. This is problematic because performed by the 8, the 4, the 38, the tooth number 38. This is the internal image taken with a microscope, and this is the yellow tissue is the decaying tissue eroded by the resorption. So I performed the root canal therapy and the reparation with a root repairing material. After the extraction of the tooth of the 38, I will perform a repairing by the external part with the composite. This is an invasive cervical resorption. The colleague that sent me the patient thought this was a carious lesion, and this is a very important mistake, because when you see this, you go through the pulp, you treat the pulp, you perform a normal root canal therapy, but how? You cannot enter by the palatal surface, because if there is a lesion in the cervical part and you perform a hole in the palatal part, you condemn this tooth to the extraction, because there will be a poor remaining material in order to face the load, the occlusal load. So using new instruments with the heat-treated alloys, you can perform a root canal therapy, and in this case, the rehabilitation is a normal obturation, a normal filling with composite. Of course, you must perform a good anatomy in order to recreate the CAJ, in order to perform parodontal mucogingival surgery in order to replace the gingival tissue. But if you go through a normal therapy and a good therapy with the good protocols, you can reach these results. And this is the DRX. Okay, my time is on because I'm speaking from 47 minutes, and now I'm here for you for every question, every doubt, everything you need. So I thank you so much for being here and listening to me, and I hope this topic was interesting. And now tell me anything you want.
Thank you, Doctor, for the amazing lecture. So guys, don't hesitate. If you have any question for Doctor, we're going to start our Q&A session.
I have all the time you need. So let's go to the chat. Okay. You can type it, you can ask it. In my dreams, all the things I said are clear, but I don't think, because it's a very difficult topic also for clinicians. So can you please share your slide? I cannot share all the slides because they are not mine, not all mine, because I'm a part of a group study, so I have to ask before for my colleagues. If they agree with me, I will send you. Not the clinical cases, because I cannot share the clinical cases, but if possible, I will, of course. And now I can ask you if the classification, in your opinion, is difficult to understand or is simple, because the classification by Edersey, let's get there. Let's get back there. Where is it? Here. This classification is a two-dimensional classification, so simple to understand. The 3D classification is a little more difficult to understand. Let me see, Greta. What can regular dentists do to stop resorption profit before patient gets in the endodontist? Well, it's a good question because general dentists first must understand the situation. And this is the most important thing. What to do? Nothing. Because if there is no pain, and often there is no pain, it's better to relate the patient to the endodontist. If there is pain, first thing is to block the pain. So to make to open the chamber in order to perform a normal initial root canal therapy in order to stop the pain. Your only objective must be the pain. And further thing, better to relate to endodontist. You said trauma stimulation are requirements of a resorption. What kind of stimulation? Mechanical or chemical? For example, orthodontic stimulation. For example, occlusal stimulation. If there is a patient that is in normal clench, that can be the first step for the resorption. So there are a lot of stimulation, but all the stimulation are related, all are related with the pressure. Where there is a pressure on the tooth and there is the first damage, can be a resorption. Of course, resorption is not spread like carious lesion. I'm an endodontist, so I see a lot of resorption. I treat traumas at the university, so I see a lot of trauma. But a normal dentist, a general practitioner, I think can go through a resorption once or twice per year. So don't be so afraid about this. What would be the management approach to discoloration caused by root repairing material? This is a problem because root repair material must not remove because they are working. And the first generation of root repairing material, I'm talking about MTA, mineral trioxy aggregate, can lead to a discoloration. You can try an internal bleaching, an external bleaching, but the problem is about the bismuth oxide that lead to a gray coloration. So often prosthetic approach can be the only result. Okay, the session will be on YouTube. Good. And if there are other questions, I'm here for you. If there are questions that comes to you next days, don't be afraid about writing me. Your colleagues have my mail, and I can share maybe one other thing. Wait for me just for a moment. I'm sharing with you. Where is it? I'm showing you a slide that can be a simple way to contact me, but I cannot find it, of course, as always. Where is it? Where is it? I ask you just a second of patience. And in the meantime, if you have questions, of course, tell me. Relations, there it is. Okay. Maybe amen. Well, How can I share it? Here it is. Okay. In these places, if you see the screen, you can find us, me and my colleagues of my team, for every question, for every problem, every problematic case you find. You can find our cases in order to understand how we manage this situation. And this is the QR code in order to follow us and to join us and share your knowledge with us. So I don't see other questions.
All right. So thank you, Doctor, for the session.
I thank you so much. It has been a real pleasure for me.
It's rare to see this point of view in endodontics, to study resorption. So we learned a lot. I learned a lot personally. I'm sure others did. And so if you guys don't have any more questions, please fill in the feedback form. I'm going to share it again on the chat.
Okay.
All right.
And just one thing, if you come in Milan, come to my clinic, write me, and we can see maybe some cases together. So don't be shy, write me.
Thank you, Doctor. I'm sure. Thank you for the invitation. It's very nice of you. So if you guys don't have any question, we're going to be closing our session. See you guys next month for the Middle Eastern region July Webinar month. If you guys didn't register yet, please do. And please also visit ShapeIT, the channel session, for more information from Dr. Marco. And have a nice day, everyone.
Goodbye.